Klik dekat ni. Boleh. Dia gabung dengan yang awal, dia terkali. Oh, orang jadi pula kan. Send YouTube link. Boleh. Boleh. Sebelum nak send tu, ada WhatsApp. Mohon subscribe dan share dah. Kalau kita nak ni kan. Saya tak kumpul ayat lah. Okay, saya nak kaya raya untuk kita sama semua untuk subscribe dan share. Like, apa? Like, subscribe, share. Like, share, subscribe. Okay.
Bila kata kita start 8 suku dia kata sebab tak ramai lagi.
Okay. No problem. Kita dah anda pergi akhirnya semua lah. Okay.
Hospital seluruh Kelantan yang jaga COVID dengan PKRC. Asmen ada tapi dia orang dekat Dewan Datuk Aziz dekat Silama. Tapi satu komputer je lah. Oh. Tanya kenapa tak tukar nama presenter?
Oh, nak tukar nama presenter ke?
Tak payahlah. Oh, ingatkan presenter.
More than 200 and more than 100.
Kalau edit dia tak boleh edit.
Dia gini, kalau dia boleh fill and sign kan. Tak, kita boleh untuk pertama kali tak daripada raw ni. Sebab biasa form yang kosong, kita pakai fill and sign kita boleh tak nama tu. Lepas kita simpan je pakai PDF. Ni saya tak mute ni, kita cakap semua dia orang dengar. Ni video, saya on video. Tak tahu dia. Lek, nampak video ni? Nampak? Okay. Video kan? Video. Tak ada gelap ada kan tengok mak ni. Sound aku, dia boleh. Kalau yang lama kat ni. Oh, sebab ni pun boleh tutup. Kalau baru.
Tu apa?
Yang
CPG.
PG tu.
Aha,
Dia
aha.
bergaji dah dalam
Aha.
surat tu. Cuma nanti saya bagi kat doktor balik lah.
Oh, bukankah dulu dah ada?
Masuri still as Masuri, you know. Faham tak? Aku semalam ada patient yang OHS intubated tau. Barang besar
Oh dia. Okey, ni tak ada cerita. Sebabnya set-set standard nak pergi nawak hoksi lain lah, tapi tunggu result RTK hoksi.
Assalamualaikum warahmatullahi wabarakatuh. Semua boleh dengar Boleh tengok slide, boleh nampak slide? Kalau saya nak gerakkan slide ni macam mana?
No, ni je. Ni. Up down.
Okay. Alright, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah wassalatu wassalamu ala Rasulillah. My name is Dr. Muhammad Aizat bin Amiruddin. I am a clinical specialist in Hospital Raja Perempuan Zainab Kota Baru. So today I'm going to present on this slide, which is provided and done by Dr. Suresh, our ID physician in Sungai Buloh, on the updates on management of COVID-19. So it's the slide is quite tight and lengthy, so kita akan go through dengan lebih cepat sikit lah. We will focus more on the difference or the important points throughout the slide. So how does COVID-19 spread? As we all know, it's primarily by inhalation of droplets and aerosol. Okay, so the risk of transmission is of course the greatest within 3 to 6 feet of the infection source, hence the 1 meter jarak lah. Okay, so deposition of virus also, right, in exhaled droplets and particles onto exposed mucous membranes. So this is why we not just wear a face mask, but on top of that, our face shields to protect our conjunctival mucous membranes. And also, of course, touching the mucous membranes. If you have touched someone who's already infected with the virus, and you have the virus on your hand, when you touch the mucous membranes, also can infect and transmit the virus through that. So when can it be airborne? It is primarily through aerosol and small droplets, but it can be airborne in certain situations. Number one, in enclosed space with inadequate ventilation or air handling. So in hospitals, in clinic kesihatan, or in the clinical punya setting, usually when they eat together in the pantry, solat, when they do not have good ventilation in that area, so this might increase the chance of transmission, okay, of COVID-19 from a person to another. So when you are in enclosed space, try to increase the ventilation by opening the window, opening the door, so that we increase the ventilation and hence reduce the chance of transmission of COVID-19 or whatever airborne virus that we have. So increased exhalation of respiratory fluids also may increase transmission and make it airborne. For example, exercising, napas laju, shouting. Kalau ada yang suka menjerit tu, suruh dia jangan menjerit sikit lah. Masa COVID ni. Singing pun sama juga. Yang suka nyanyi dekat dalam pantry ke, kat mana-mana ke, sikit dia tone down sikit. Sebab boleh menyebabkan transmission of COVID-19 dia jadi airborne. And prolonged exposure to these conditions, typically more than 15 minutes. Okay, so this is the natural history of COVID-19 virus or SARS-CoV-2. Right. Previously, we are very well known of this kind of chart for dengue. Kan? Sebelum adanya COVID-19 ni, so the dengue adalah satu daripada the big thing lah. So now it's COVID-19. So from the very beginning, the early stage usually it's mainly viral response phase where there will be viremia, viral replication. Okay. And it's followed by stage 2, whereby there will be initiation of pulmonary involvement. Okay, so in this stage 2 is actually an overlap between the viral response phase, the viremia, and also the host inflammatory response phase. Macam dengue juga. At one point, dia ada host inflammatory response phase kan. So phase 2 and then phase 3 adalah phase 3 adalah hyperinflammation phase. Okay, whereby the CRS, cytokine release syndrome that usually happens in Cat4 and Cat5 happens at this stage. So as we mentioned before, at early stage or early infection, from the incubation to the mild symptoms, so the patient will usually be asymptomatic or flu-like symptoms. Okay, usually this reflects or manifests as category 1 and 2. And then on the phase 2A and 2B, usually it will be Cat 3 and 4, whereby Cat 3 is pneumonia, okay, and Cat 4 when the patient starts to use need oxygen, hypoxia and needs oxygen, all right, and Cat 5, usually the CRS phase, the very severe phase of CRS, which is the hyperinflammation phase, okay. So usually patient yang tak teruk sangat, dia datang daripada clinical category 1 and 2, okay, asymptomatic or mild symptomatic but no lung involvement. So Cat 3 is there is lung involvement and chest X-ray changes, but patient is not hypoxic. So Cat 4 is when the patient starts to need oxygen supplication supply, and also Cat 5 when the patient is intubated. All right. How do we diagnose COVID-19? So from the symptoms, COVID-19 is primarily respiratory, but it also has other symptoms. For example, the most common that we encounter, of course, fever, cough, and shortness of breath. But on top of that, patients also may complain of fatigue, which is a very subjective symptom, and also very hard to identify in patients, and patient usually doesn't point out fatigue unless we ask them. Okay, biasanya dia akan cakap rasa badan tak sedap lah, kan, muscle or body aches and headache, new loss of taste or smell, hypoxia dengan anosmia. So this is actually somehow is unique to COVID-19. Very rare we have other viral illnesses that have the same symptoms. Other than that, of course, sore throat, congestion, or runny nose. Also GI symptoms. We at times we also encounter patients with these GI symptoms. Okay, so diarrhea, nausea, and vomiting. It also can be because of the virus itself, COVID-19. So what is the clinical criteria for suspect phase? Right. So this suspect phase actually requires clinical and epidemiological criteria, both. Okay. So the clinical criteria would be acute onset of fever and cough, all right, or acute onset of any two of these, all right, fever, cough, general weakness or fatigue, headache, myalgia, sore throat, coryza, dyspnea, anorexia, nausea, vomiting, diarrhea, altered mental status. So the definition is broad. Now, last time we used to have the definition of acute onset of fever and respiratory symptom, but now as we encounter more and more COVID cases, so we understand better that they do not necessarily present with just respiratory symptom. They may as well present with other symptoms macam altered mental status, for example, and it's maybe because of hypoxia, yeah, or any other causes. Yeah. GI symptoms, coryza, dyspnea, headache, myalgia. So we have to be more aware of these symptoms when the patient present to us. So this is particularly important in primary care. So we really hope that those who are in primary care can detect this at an early stage. Okay. So the definition of probable case, of course, the one that we have a positive RTK antigen, okay, alive or dead. So number 2 is a suspected case with chest imaging, showing findings suggestive of COVID-19, all right, chest X-ray. And patient who meets clinical criteria and contact of a probable or confirmed case or linked to a COVID-19 cluster is also considered a probable case. A person with anosmia or hypoxia, death, not otherwise explained in adult with respiratory distress preceding death, and was a contact of a probable or confirmed case. All right, so these are the definitions of probable case. Okay. So what is the definition of confirmed case? So as recently taken by Jabatan Kesihatan Negeri, whereby a positive RTK in predetermined areas and locality, there are 6 localities and in Kelantan, whereby the prevalence of COVID-19 is more than 10. Okay, so recently we have taken the RTK antigen as confirmatory in this area, whereby the prevalence is more than 10%. So other than that, a person with a positive molecular test, either PCR or gene expert. So this is the nature of the infectivity of SARS-CoV-2, COVID-19. Okay, when the patient is exposed to the virus, all right, so there will be incubation period of around 5 to 6 days. Okay, then after the incubation period, the viremia will start to shoot up, and this is where the patient becomes most infectious, and this is also the point where the patient becomes symptomatic, because the virus level is at a peak at this point, and the patient become infectious. And afterwards, at about day 10, but not necessarily around day 10. And the patient, the virus will start to decline and the patients become less infectious and finally not infective anymore. So as you can see, they compare the positivity or the sensitivity of RTK and also PCR. Okay, the first line at the top is actually the RTK, whereby it does not detect the low viral load or patient basically with high CT value. So at the point of before the peak of the infectious period, okay, and then afterwards, the RTK is actually lower in sensitivity in detecting COVID-19 as compared to PCR, which is more sensitive and detected lower viral load with higher CT value. Okay, so that is why some patients with RTK negative, not necessarily we can safely rule out. So we have to really ask the patient about the clinical background, the day of illness, and which point actually the patient presenting to us, so that we can further clarify whether this patient needs a PCR repeated to further confirm the case or not. So this is a study done in Tennessee and Wisconsin in US, saying that 75% of infections identified within 5 days of the index case. So the incubation period usually lasts about 5 to 6 days, the median, but they mostly become positive at day 2 to 12 days after exposure. Okay. Also, there's a note down there. Using PCR, day 5 after exposure is 38% false negative rate, whereby when the day increases, and the false negativity rate is reducing, meaning it's more and more sensitive with the more days of illness. Okay. There's also a phase whereby the PCR still detects the presence of the virus in the body, but at this point, the patient is actually not infectious anymore. Okay, so it is called the post-infectious phase, whereby the viral load is below the threshold whereby the patient is infectious, but the PCR still remains positive. So at this point, we really have to determine the clinical part of the patient's presentation. At day what of presentation is the patient in? All right. So it could be because of viral shedding, whereby the patient is post-infectious and it's not infective anymore. That virus. Okay. Usually, patient at this phase will have very high CT value, meaning the viral load is very low. Okay. So they are not infectious anymore. So antigen test sensitive, which is the RTK antigen yang biasa kita buat tu, sensitive enough to detect cases with high viral load. Okay, pre-symptomatic. So it is usually we use for patient who is pre-symptomatic or early symptomatic disease. Okay, up to 5 days from symptom onset, and also it has low RT-PCR CT value of less than 25. Okay, the lower the CT value, meaning the higher the viral load. Okay, so usually RTK antigen can only detect those with high viral load, and also with low CT value. Okay, but it cannot detect patients with lower viral load with higher CT value. Okay, so I will show in the later slide. So this is also developed for testing in symptomatic person, all right, and not currently recommended for use as in asymptomatic person. So this is a comparison of a few different types or products of RTK antigen kit. So as you can see, most of them become very sensitive at a higher viral load, okay, and lower CT value. So at the point of low viral load, the sensitivity is actually that differs from 20 to 60%, which is very low. Okay, so when you start to have high viral load, okay, when you use RTK antigen, the sensitivity becomes more than 85%, as you can see. All right, so it is actually recommended for those who are having high viral load, and it is actually can detect patients with high viral load. So this is the timeline as outlined by a study in China. Okay, so usually in Cat 2 to Cat 3, the patient will be around 9 days, and on day 11, patient will be in Cat 4, and 3 days afterwards, patient will be in Cat 5. All right, but the range there is around 7 to 12, 9 to 14, and 2 to 6.5 days. So this is a local study done in Malaysia, an observational study. All right, as we can see from the very beginning, the total number of samples is 6,368. So from the incubation period, around 50% saja yang develop symptom. Okay, another 50% actually no symptoms, and the infection actually stops. All right. So ada lebih kurang 50% saja patient yang ada simptom from all patients yang ada COVID-19. On top of that, from those 50% yang develop symptom, 80.2% has mild to moderate disease. Okay, and they recover after that. Only 11.8% develop severe disease from the 50% yang tadi itu. So only out of 6,300, only 379 patients develop severe disease. Okay, which is very little, tak banyak pun sebenarnya. Out of patients who develop severe disease, okay, 62.3% goes into the critical care, right? And 37.7% recover without needing critical care. And from those who are in ICU, 65% survive. And about 1/3 of them end up succumbing to the illness. 1/3. So as a summary from this is a Malaysian study. So 6% of the patients develop severe disease. Those requiring some supplemental oxygen, which is Cat 4 and Cat 5. So daripada banyak-banyak tu, 6% saja yang Cat 4 dan Cat 5 lah, mengikut study ni. Then only 3.7% of the total required ICU care, and 1.3% of the total died. So this is actually much higher than the current death rate lah. Kalau kita tengok kita punya death rate hari semalam pun dalam 0.3%, which is actually quite good juga lah. Although you know the death cases actually it's still exceeding 100 patients lah, which is quite saddening juga. Okay, so we go that one. We have finished talking about the background of the disease. So now the most important part, which is the management of category 1 to 3. So what is the most important points in managing patients with Cat 1 to 3? This is particularly important in the primary care. Those in CAC, PKR, sebelum masuk PKRC, in primary care lah basically. So number one is the most important is risk stratification. So throughout the slide, we will understand which patient actually at risk of developing more severe disease. So these kind of patients should be monitored closely and admitted to hospital. Okay, ataupun in a higher setting lah. So so risk stratification is very important. Number two is warning signs and symptoms. So we have to understand and learn by heart what is actually the warning signs and symptoms so that we can be aware of it and we can stratify the risk and put the patient ataupun allocate the patient into the suitable setting. Okay? So early detection of hypoxia, pulse oximetry, exertional dyspnea, okay? And ask the patient regarding those kind of questions. Okay, so this is a very important chart whereby we actually try to explain that patients with comorbidity actually have much higher risk of developing severe disease and progressing to Cat 4 and Cat 5 as compared to those without comorbidities. And on top of that, the age also plays a role whereby the older the age, the higher the percentage of deterioration to Cat 4 and Cat 5. So this is actually the basis of the criteria of patients who has to be admitted to PKRC or cannot HIO at home or even have to be admitted to the hospital. So these two are the most important factor that determines the risk of the patient. Number one is the presence of comorbidity. Number two is the age of the patient. So as you can see from the graph, patients who is more than 60 years old with comorbidity has 16.9% of them developed to category 4 and 5. So that is actually very high. Okay, as compared to those less than 40 years old without comorbid, only 0.48% progress to Cat 4 and Cat 5. This is again a relative comparison to patients who is less than 40 years old without comorbid. Okay, the higher the age and the presence of comorbidity actually becomes, the more the comorbidity and the higher the age, okay, the older the age, the more the risk of getting severe disease. So those slides are about risk stratification. So this is actually, again, we explained regarding the clinical category 1 to 3 with the day of illness, the early phase until a certain day, 7 to 8, is actually a viremia phase or the viral response phase, okay? And at this point, usually patient develop categories in some other, either asymptomatic category 1, symptomatic category 2, or with lung involvement category 3. At a certain point, between the overlapping of the viral response phase and host inflammatory response, the patient will start to have warning signs. So what are the warning signs? So number one, of course, the symptoms. So this slide is to be remembered by heart by all personnel managing COVID-19. Again, especially for those in primary care. Yeah? For the symptoms, patient will have fever, exertional dyspnea, and persistent cough. And any persistent symptoms, for example, lethargy, poor appetite, and nausea. On examination-wise, of course, when the patient is tachypneic and hypoxic saturation less than 95, or exertional dyspnea. Okay, so the 1 minute exercise test is also very important, very useful to determine this. Okay, so laboratory-wise, in a rising CRP, or the single CRP less more than 5 milligram per deciliter, or dropping ALC, or single ALC less than 1, absolute lymphocyte count, okay? So, and another point that is important in the laboratory part is actually the neutrophil lymphocyte ratio, which is more than 3.13. Okay, meaning the higher the neutrophil and the lower the lymphocyte. Okay, so they are most likely going to go into severe disease. Okay, and of course, when you have radiological finding on chest X-ray, which is also a warning sign. So those with warning sign has to be monitored in a higher setting, a higher care setting. Okay. So early detection of hypoxia. Other than that, sorry, people with warning symptoms and signs, yes, you have to look for hypoxia diligently. So you patients with persistent or new onset of fever, persistent cough, lethargy, okay, and picking up hypoxia early, ask about exertional dyspnea, count respiratory rate full for 1 minute, and do 1 minute sit and stand test, like I said before. So those who are having warning signs, it's very important for you to pick up to really determine whether this patient is hypoxic or not. And when you pick up someone at home by ambulance, for example, please make it a habit to check the saturation, the vital signs before sending to some other ED ke PKRC, because that will determine where the patient should go. Alright. Biasanya kalau patient kita call dapat call ambulance call di rumah ni, kalau history dia memang very suggestive of having warning signs or warning symptoms lah, kan, macam lethargy ke, persistent fever or cough, make it a habit to detect hypoxia early. So you actually pick up the hypoxia early. Number one is silent or happy hypoxia, whereby the patient may not be breathless, but when you check the saturation, it's actually very low. So it is very important to check the SpO2 of the patient, and regardless of the patient not complaining of dyspnea. Okay. So you also have to watch out for patient compensating by increased respiratory effort but not feeling dyspnea. Sometimes patient kalau tanya, ada sesak nafas tak, lelah tak? Dia kata tak ada. Tapi kalau kita tengok nafas dia, kita tengok cara dia bernafas tu, ada macam actually respiratory rate dia tinggi, okay, ataupun dia gunakan accessory muscle. Tapi dia tak complain of sesak nafas, for example. Okay, so these patients, so you have to detect the hypoxia, kan? Sebab to prevent the progression of the disease. Okay. So in category 1 and 2, 3, of course you have to ask the screening questions, fever, persistent cough, dyspnea, usually in PKRC lah, ataupun patient yang daripada HIO yang CAC. Nausea or vomiting and lethargy. So watch out for warning signs. Lethargy, confusion, tachypnea, desaturation, exertional desaturation, heart rate more than 100, raising CRP. This one is hospital setting ataupun PKRC clinical. Okay, of course at the blood investigation you have to check the blood on admission and also repeat at day 9 or 10. This is for Cat 3. Cat 4 and Cat 5 of course it's different. Okay, so you have to review TDS. I mean this is ideally lah. Okay, so this is another new findings or new issue that we are facing, whereby patients, the more patients we start on steroid, the more complication that we see afterwards, after the patient has recovered, or actually the late towards the disease lah, towards the end of the disease. Okay. According to the recovery study, as you can see, dexamethasone actually benefits patient most on for patient with invasive mechanical ventilation or intubation, and on top of that, patient on oxygen supply. But if the patient is not on oxygen, actually the usual care is better than dexamethasone. So we do not recommend, according to this study, we do not recommend to give dexamethasone for patients who are not on oxygen. So the dose used in this case is actually 6 mg daily for 10 days. Okay. When is it too early to start dexamethasone or steroid? Number one, once the patient is not hypoxic. Okay. When the patient is no desaturation, so it's considered quite early to start steroid for this kind of patients. Number two is in the first week of illness. Okay, from day 1 to day 7 of illness. Okay, usually this kind of patient is in viremia stage. Okay, not yet in the inflammatory stage. So if you give steroid in this patient, there could be worsening of viremia, and which may cause, in turn, will cause the worsening CRS later in the disease. Okay. Number 3 is low CRP, patient with CRP of less than 50 mg per liter. So try not to start steroid in this kind of patients without the presence of hypoxia. Okay, and also with those with NLR ratio, low NLR ratio. Okay. So regarding the antiviral, previously there have been a few antivirals being studied. For example, favipiravir, remdesivir, and also Caletra, for this kind of patients. But unfortunately, none of those actually have a convincing positive effect on patients with COVID-19. Okay. Prevention of complication. Okay, so treatment of antiviral treatment. Sebut kat sini treatment of COVID-19 antiviral memang tak ada yang berkesan. Okay, so far lah. Prevention of complication, of course, we have to prevent from clotting ataupun thromboembolic events in COVID-19 patients, and of course we have to treat the early treat the complications early by starting steroids. Okay. Favipiravir is one of the antiviral that is being discussed or being studied. Usually most of the studies actually have not proven the efficacy for patients with COVID-19. Okay, so most likely to be effective in the viral phase of illness. So when do we use it? Favipiravir in high risk group who is category 3 or symptomatic but within the first 7 days of illness. So is there a role for patients in Cat 4? So not known. So these are the common side effects of favipiravir: hyperuricemia, diarrhea, elevated transaminase, and neutropenia. And it is also teratogenic. Okay, so we avoid in patients with kidney disease, especially in patients with GFR less than 30 mL per minute. Okay, so this is comparing a few types of antiviral. It has been studied for patients with COVID-19. So they compare from the rate of mortality from control and also the antiviral. Most of them actually showed no clear benefit. And in interferon, for example, actually the in-hospital mortality is actually higher than control. Okay, so no antiviral actually has shown clear benefit in treating COVID-19. Okay, this is another hot topic nowadays. This is the ivermectin. So I think most of us know that WHO only advised ivermectin in clinical trial setting only. All right, and nothing more than that so far. And of course, there has been a few studies regarding the ivermectin previously, which actually most of them favors ivermectin as compared to control. But yet, we are still on in Malaysia locally. We are still ongoing conducting a study on ivermectin treatment for COVID-19 patient. Okay, the study is still ongoing. We just started in May. So this actually going to lebih kurang sama macam heavy previous study last time, whereby our target population will be symptomatic mild to moderate hospitalized COVID-19 patient who are 50 years and above, okay, with comorbidities and within first 7 days of illness. So this study mainly to look at whether ivermectin can prevent progression to more severe disease in high-risk patients. Okay, so this study is still ongoing. So now our population or our patients involved is actually in hospital Tumpat. So like we said before, the category 2 to category 4, category 3 to category 4, the progression is between 9 to 11 days. And then the patient goes into Cat 5 and recovery phase. Okay, so this is very important for those in hospital setting and also in ICU setting. How do you differentiate whether this patient is still in inflammatory phase or already into recovery phase? Okay, so usually inflammatory phase happen in second week of illness, day 7 to 14. But it is also stressed. The point is being stressed here that onset of disease could be subtle. So day of illness, not accurate always. This is particularly true when you see patients in emergency department. The first time you see the patient, when you ask about the history, the symptoms may have started like 2 to 3 days according to the patient. Dan berapa hari tak sihat ni? 4 hari. But the chest X-ray looks very, very bad. As if he is already in inflammatory phase, as if he or she has already entered the week 2 of illness, more than 7 days. Okay, so this is just an example. So at this point, you must use your clinical judgment whether to take this patient as early or already inflammatory phase, because the management really differs. If you are not sure, please consult with your superior. Okay, usually preceded by warning signs or symptoms like we have already explored before. So patient will have increasing CRP and increasing neutrophil lymphocyte ratio, and on top of that, patient will also having progressive hypoxia. So how do you tell that this patient is already in recovery phase? Usually, the patient is week 3 of illness or 3rd week of illness. Okay, clinically improving, feels less breathless, not tachypneic, and also patient feels less lethargic and starting to ambulate. Of course, the oxygen requirement is decreasing and dropping CRP. Why is it important to identify recovery phase? Because to know when to de-escalate our treatment. Okay, so that we can reduce the use of steroid in this kind of patient. When the patient started to show improvement, so it is the time to de-escalate our steroid use. Those patients on high steroid need to be reduced to a lower dose of steroid to avoid complications. And those with IV steroid need to be changed to oral steroid. Okay, so patients who are in recovery, usually the recovery phase ni only applies to patient with degree 4 and 5, the inflammatory, hyperinflammatory state. When the patient is feeling less breathless, decreasing oxygen requirements, starting to ambulate, and CRP levels are dropping. So these are the features of patients who are in recovery. So what should we do in this kind of patients? Number one, we should convert to oral dexamethasone if the patient was in IV before. So stop doing daily bloods, only those that we want to monitor and we intend to intervene. Baru kita repeat dia punya blood lah. So start discharge planning when patient is already showing the signs of recovery, dah boleh start dah. Bila nak discharge, bila nak di-isolate, kan? After di-isolate, where do we have to follow up the patient? Is it in our respiratory clinic or is it in the klinik kesihatan sahaja? Ataupun tak perlu apa-apa appointment afterwards when the patient is very well. So another issue is of course the diabetic medication. And when the patient is on high steroid, they will have high sugar, of course. Most of them will have high sugar, whether in patient previously diabetic or not. So this has to be taken into consideration when you want to adjust the medication and discharge the patient, and you have to think of what the patient should be discharged with after the patient has been discharged, after the patient has recovered. Some patients will be discharged with steroid. So their sugar will remain high to a certain point. But after we take off the steroid, we have to remember that the sugar will start to go back to normal. And so there must be a certain kind of monitoring to make sure that the patient has optimum sugar control. Kalau tidak, kalau kita discharge patient dengan insulin, yang high dose insulin sewaktu dia on steroid, and we do not adjust the sugar or the insulin level, the patient will go into hypoglycemia. So it's very dangerous. So that's why you have to discharge the patient with some with follow-up in klinik kesihatan, for example, to make sure that the sugar level is optimized. Okay, some patients can be transferred to step-down ward, for example, ICU to HGW, HGW to normal COVID ward, or even some from COVID ward to PKRC, or from ward or PKRC to HIO at home if the patient is deemed to be stable. Okay, but still remember that this kind of patients who have already gone into recovery still can deteriorate due to either secondary infection, pulmonary embolism, or worsening comorbid, or organizing pneumonia. So if someone is already in recovery phase, we know that the patient has had a very bad lung involvement previously, try not to aim the saturation very high, okay? So SpO2 more than 92 is good enough for patient, especially for patient who has very severe disease previously, very bad chest X-ray, very bad hypoxia, needing very high oxygen, okay? And also, we have to switch this patient from IV to oral dexa, no need daily bloods, and transfer down to step-down care. Okay, so this is also a very important point. Kat bawah tu, such patients can still deteriorate due to secondary infection, pulmonary embolism, organizing pneumonia, and worsening comorbid. So the secondary infection is what we are afraid of when we give patients too much steroid. So when they are immunocompromised because of the steroid, especially in ICU setting or HGW setting, so they tend to get more sinister infections afterward. Yeah. So we have to be really careful with our steroid dosing, timing, and also de-escalation. So PE is another possibility, and not mentioned here is MI, ataupun stroke, also a thromboembolic event that may happen in patient who is already in recovery phase. Okay. And of course, organizing pneumonia, we are seeing more and more organizing pneumonia recently, and worsening comorbid. Okay, if someone is in inflammatory phase, aim for an oxygen saturation of more than 96%. Okay, and also adjust the oxygen requirement based on work of breathing. So this is very important. There is no one blanket rule for everyone. All right. So not everyone we have to target oxygen more than 96%. Because why? Some patients, they are comfortable with a certain oxygen saturation, even if it's lower than 96. For example, 92%, okay, but he's not really tachypneic, because he's already okay with that kind of saturation. Okay, so patient could be maintaining the saturation by breathing fast with effort. So this kind of patient, we need to give more oxygen, Okay, meaning because they are not actually comfortable with that kind of situation, so patient may need a higher oxygen level. All right. So on the other hand, patient could have hypoxia but not need respiratory distress due to shunting. Okay, happy or silent hypoxia. We also have encountered many of this kind of cases like before. So teach patients self-proning. This is also very important. We have the article or risalah on proning that is to be given back to patients. So also we have to advise complete rest in bed as much as possible. Okay. So this is the oxygen dissociation curve, whereby the increment, once the PaO2 achieves and above, there's not much different in the saturation anymore. Okay. So the problems that we are having with steroids. So this is a statement by the Malaysian Society of Intensive Care, whereby they limit the amount of steroid given to patients with COVID-19. As you can see here, steroids are not indicated in patient without oxygen. So patient with nasal prong or face mask, only 6 milligram OD for 7 to 10 days. Okay. And patients with high flow nasal cannula or non-invasive pneumonia ventilation or intubation, they will give 20 milligram OD for 5 days, then 10 milligram daily for 5 days. That's it. Okay, so this is quite different from what we have been practicing before. We used to, until now, we practice 0.2 mg per kg, okay, and slowly tapering down, or either 0.2 or 0.4 mg per kg dexamethasone and tapering down. So the tapering down is quite long, okay, as compared to this regime that has been given by the Malaysian Society of Intensive Care. So also regarding patients in pregnancy, they suggest dexamethasone only for patients 24 to 34 weeks. It's because of the benefit of DEXA in lung maturation of the fetus. Okay, and before 34 weeks and above 34, they suggest prednisolone or hydrocortisone. Okay, so this is the treatment algorithm for patients who need steroids, which is implemented in Hospital Sungai Buloh. So by default, patients who are hypoxic, okay, they will start on 6 to 8 milligram IV and 12 milligram if the patient is obese, BMI more than 30. Okay, if the patient goes into more severe hypoxia or raising or persistent high CRP, in other words, if the patient deteriorate while on low dose dexamethasone, they will increase the steroid methylprednisolone 2 mg per kg or high dose dexamethasone 20 mg OD. And then if patient still becomes more hypoxic ataupun patient still not improving with the methylpred atau dexa, again they increase to methylpred 2 mg per kg plus tocilizumab 400 milligrams. This one is according to weight and tocilizumab. But as soon as the patient improve or responded to the whole treatment, they will de-escalate to the previous treatment. Okay. So I've discussed this matter with Dr. Anila. So there is a discrepancy between our dose of steroid and also the Sungai Buloh punya practice. So as from now, I think we can start to practice this dosing. Yeah. So start with 6 to 8 milligram IV and 12 milligram for those who are obese, and escalate to methylpred only when there is a deteriorating event. Okay, and give tocilizumab if patient further deteriorates. Okay, so how do we step down the dosage? Okay, in guidelines. So it's actually recommended that we step down as soon as possible. Whenever the patient is improving or showed response to the high dose steroid that we are giving, we should de-escalate the dose of steroid as soon as possible. Okay, not to give the patient on prolonged steroid therapy. Okay, so if we start the patient on high dose steroid, it is actually no proven therapies for that. Okay, but it is done more out of desperation. Okay, because of the acute fibrinous organizing pneumonia. Okay, so we don't know if high steroids do more harm than good in the long run. Still no study regarding that. should be used as pulse therapy beyond 3 days only in exceptional cases. All right. So usually the high dose methylprednisolone, we try to keep it from 3 days at maximum 5 days lah, before we see any improvement, and then we start to de-escalate the steroid therapy to avoid further complications such as GI bleed ataupun secondary infection, especially those in ICU setting. So as soon as the patient improves, we have to step down our therapy, and also step down if patient condition is static but CRP levels are down. So CRP is one of the markers of the cytokine release syndrome, or the CRS, in COVID-19 patients. So when you see the reducing CRP, it is safe to reduce the amount of steroid. So this chart actually shows you how steroid can be harmful later in the disease. Okay, so when the patient in the second week of illness or in the inflammatory phase or hyperinflammatory phase, yes, the patient will benefit from steroid. However, when the patient is on steroid for too long, the patient will develop secondary infection risk. The mortality risk is higher. Okay, although the inflammatory response is lower, but the patient is at risk of having these two complications. Okay, secondary infection and mortality, and also the one that is not mentioned here is bleeding tendency or a GI bleed. So that is why you have to be very careful and very thoughtful of in our steroid prescription to COVID-19 patients. Okay, this is regarding tocilizumab. Okay, which patients that recover that needs tocilizumab or indicated for tocilizumab therapy? Okay. I personally, and we as our team in HRPZ, have seen tremendous improvement for patients who have been given tocilizumab. If we choose the candidate, select the candidate correctly. Okay, so which patient will benefit from tocilizumab? Number one, those who are having or completed a course of steroid such as dexamethasone, unless they cannot have corticosteroid. Those who have not had any interleukin-6 inhibitor before, and there is no evidence of bacterial or viral infection other than COVID-19 that might be worsened by tocilizumab. Okay, so the number 3 is also very important, whereby we do not want to give an immunosuppressive therapy for patients who are already in overwhelming sepsis or infection. So that is why we always request or ask for PCT, procalcitonin, on this kind of patients that we are going to give tocilizumab, to weigh the benefit and the risk of tocilizumab, of giving tocilizumab in this kind of patients. So if the PCT is not too high, meaning there is no overwhelming sepsis or bacterial infection, it might be safe to give tocilizumab for this kind of patients. So, and they either need oxygen supplement or have CRP more than 75, or are within 48 hours of starting high flow nasal oxygen, CPAP, or non-invasive mechanical or invasive mechanical ventilation. So these are the kind of patient that we give tocilizumab. So the dose is 8 mg per kg, but some patients we do give at 4 mg per kg. So also an interesting fact to be highlighted here, the price of tocilizumab of 400 vial is 2,560 per vial. So one patient, you want to give 400 mg, harganya adalah RM2,500. So please fikir 2-3 kali, 4 kali, 5 kali sebelum bagi tocilizumab, whether this patient may really benefit from tocilizumab or not, and be selective in giving this medication, and also always discuss with your consultant before giving your tocilizumab. So this is the hypercoagulability. As we all know, COVID-19 has tendency to increase the hypercoagulability state in patient, hence causing the thromboembolic event. So this kind of patients need anticoagulant. So those who we suspect PE or in the ongoing thromboembolic event, we give 1 mg per kg PD. High prophylactic dose for patients who are in ICU or category 5, and low prophylaxis dose for patients in category 4. So these are the garis panduan provided by the KKN. You can see it later. So this is the basic online course by KKM also, you can see. Also via YouTube channel. Thank you very much.
Assalamualaikum warahmatullahi wabarakatuh. Good morning. I have a question. Can you elaborate more detail about steroid use? Because you said if you give too long steroid in patient COVID-19, it will be harm. Can you explain your based on your experience or roughly timeline to give the steroid? Or any indicator to step, to de-escalate the dose or to reduce the dose. Thank you. Boleh ke title pun? Artikel security tu semua dia tadi ya? Yang tadi ke? Kena tulis kot. Kan kita tulis. Okay.